We're taking this, 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 we're taking with a pinch of salt.
Ladies and gentlemen, thank you for tuning in to another episode of A Pinch of Salt, a podcast by ERA. This month, we're returning to PD-related topics. In this episode, we're focusing on how to tackle complications in PD. Medicine is relatively simple when everything goes according to plan, but the true test of any physician is what do you do when things don't go according to plan? And since most of us don't have a lot of clinical experience with PD, usually, it would be beneficial to know how to tackle these issues and hear about the solutions from somebody who knows about these things. Dr. Sana Khan is a nephrologist from the University Medical Center in Charlottesville, USA. Her clinical practice is focused on home dialysis, specifically peritoneal dialysis. She's the author of the AJKD core curriculum paper on complications in PD. So, Sana, we're lucky to have you here. Welcome to A Pinch of Salt.
Thank you for having me.
Great. So we're just going to dive in straight to the first problem. So you have a patient that experiences a sudden loss of ultrafiltration. It used to be, 150 liters, 1,500 milliliters, let's say, but now it's just dropped dramatically. How do we tackle that? What are the options? What are we looking at? How do we solve this?
That's a good question and often seen clinically because the patient will present with concerns for weight gain, volume overload because of the sudden decrease in ultrafiltration. Oftentimes, decrease in ultrafiltration is thought to be because of membrane dysfunction. However, that would not be very rapid. More common causes of a sudden loss of ultrafiltration would be developing a fluid leak, a catheter malfunction, changes in ultrafiltration profile with an acute peritonitis, or a mismatch between what the prescription is prescribed and what the patient is doing. So common things, often the patient's history can tell you what is happening. If there's an obvious external fluid leak, the patient will complain of bogginess around their abdominal wall or in their genital areas. If there is concerns for catheter malfunction, the history will also tell you because of decreased inflow times increased inflow times and increased outflow times. If the history will also tell you if the patient has an acute peritonitis, and also if they've been unable to follow the prescription as has been prescribed. So history aside, the more concerning part of sudden loss of ultrafiltration for me would be a fluid leak. And imaging can often tell you if there's fluid leaking from the intraperitoneal cavity to either the abdominal wall, the retroperitoneal area, or the genital area. So the initial investigation would include some imaging, troubleshooting the PD catheter, ruling out any infections, and so forth. If all of this fails and you really suspect that there's a sudden loss of peritoneal membrane function, then I would recommend performing what we call a modified PET test to make sure that the membrane is working, which is dwelling the patient with 4.25% dextrose for 4 hours, and you expect to see at least 400 ml of ultrafiltration after that dwell. So it's basically 3 categories of integrity of the peritoneal membrane, integrity of catheter function, ruling out infections, and membrane function.
Yeah, that's great. You laid it out perfectly. Since you've mentioned the special PET test where you use the high glucose dwell, and you have to have more than 400 milliliters in the 4-hour time period, I suppose you also do the sodium sieving after 1 hour? And if so, how do you interpret that?
So that is a little harder to interpret, but yes, sodium sieving is a phenomenon where there is initial rapid ultrafiltration across the aquaporins that are present in the peritoneal membrane, which results in a transient increase in sodium in the intraperitoneal fluid.
I
Sorry,
think
I
you
got
wanted to
that
say
wrong. It's the
transient
other way
decrease,
around.
right?
So
Yeah,
yes,
yeah.
the other way
Yeah.
around, other way around.
Sorry.
So that is a phenomenon that happens and can cause changes in ultrafiltration if there is, again, too short of a dwell time that has been prescribed. So counteracting the effect of sodium sieving is practically done by making sure that the intraperitoneal dwell time is not too short, because that would then cause problems with ultrafiltration.
Okay, great. Thanks for pointing that out. So back to leaks. So you mentioned imaging. What do you do at your working place? Is that a CT peritoniography? Because that's what we usually do is just put the iodine contrast into one of the bags and then put that into the patient and then wait for some time for it to move into places. Is that what you do, or do you do something else?
So yes, you can do that. That is done widely across a lot of centers in the whole world, European as well as the US. However, if you are in a bind in which you don't not have a big tertiary care hospital, but you're suspecting a leak, a regular CT scan will also help track the intra-abdominal fluid and see where it is going. So CT peritoneogram is preferred, but if not available, a regular CT scan can also track the fluid and see where it is collecting.
Okay, great. Now, let's say that we did confirm a leak, perhaps into the abdominal wall through the place where the peritoneal catheter goes into the abdomen,
Mhm.
or perhaps in the genital area, whatever it might be. So how do we manage that? How do we treat that?
Again, that's a great question because it's not an uncommon complication. So the scenarios that you have mentioned, leak along the peritoneal dialysis catheter or in the genital area, is technically easier to manage than an abdominal wall leak or a retroperitoneal leak, because for managing PD catheter related leak along the catheter side or the genital area, I would recommend the patient be supine while they are doing their peritoneal dialysis. I would also recommend them being on an automated PD or cycler PD with some low volume dwells so that the intra-abdominal pressure is controlled. For males with concerns for scrotal edema secondary to a leak, often, again, supine low volume dialysis with some scrotal elevation being provided can help alleviate symptoms of the leak. Retroperitoneal leaks and abdominal wall leaks are a little bit harder to manage because unless they're along the anterior abdominal wall, the intraperitoneal pressure would be high, whether you're doing low volume supine or otherwise. It would still be harder to do. Again, the treatment would be to minimize the intra-abdominal pressure as much as you can. And if the patient can tolerate a break from peritoneal dialysis for at least 1 to 2 weeks, and maximizing medical management with low potassium diet, diuretic use, if they do have residual function and can tolerate a break, that is what I would recommend.
Great. So you can try to lower the abdominal pressure, possibly go to APD, and do that for a couple of weeks, 2, 3, 4, and see if it improves. Right. That's the idea.
Yes. Yes. Most leaks within 2 weeks should have improvement.
Okay.
Another thing that is of importance is making sure that if there's a leak along the peritoneal dialysis catheter, to give them ideal exit site care and prophylaxis against infection, because that is not something that you want.
Okay, that's a good point. So, what would you give as a prophylaxis for infection in somebody who has a leak along the peritoneal catheter?
That is a center specific
Yeah,
preference.
sure. Sure.
You just want to make sure that MRSA is not entering into the tunnel from the exit site, because that is common on skin flora. So my personal preference would either be amoxicillin clavulanate, commonly known as Augmentin, or trimethoprim sulfamethoxazole, commonly known as Bactrim, and both can be given orally without any complications.
Great. That's great information. Yeah, it certainly depends on the resistance characteristics of the place you work in, but that's good. That's good information. So let's go on to outflow obstruction. This is, I would, in my experience, relatively common in patients on a cycler, on APD. During the night, can be quite annoying for the patient with all the alarms going off and so on. So what are the most common causes of an outflow obstruction, and how do you go about trying to solve them?
Yes, it can be very problematic for patients, specifically when the alarms are going off at night or even during the day when they're trying to get their exchanges done quickly and the exchange is just taking too long because of slow outflow issues. So for tackling outflow obstruction, a few things. The first thing I would do is, before any other issues, any other interventions, is to see if the catheter flushes and draws okay with just using a saline syringe. The main causes of catheter outflow obstruction would be catheter not in the correct place if the catheter has migrated. Second would be if the patient has constipation, like there's just not enough free intra-abdominal space for fluid to float around. And the third would be if all else fails, there's no constipation and the catheter appears to be in normal position, if there's any omental wrap, which is plugging the drain holes of the catheter and preventing good fluid flow. So all of these can initially be picked up by a plain, simple abdominal X-ray. You can assess catheter position, catheter migration, and constipation is also visible. So easier solutions to that would be a laxative regimen for the patient. Oftentimes, if the catheter has migrated because of constipation, relief of constipation can have the catheter float back into the good pelvic space. And saline irrigation of the catheter can often help with outflow obstruction. If all else fails and the omental wrap is unable to be freed, then you may need some interventional radiology to help you.
Yeah. That's our experience as well. Yeah. So to summarize, first you try the inflow and outflow with a saline and a syringe, see what happens. Do the X-ray, see what's going on. Laxative treatment, that's an interesting topic. What's your favorite laxative cocktail, if I may say that?
So it depends on a patient. Oftentimes peritoneal dialysis patients are often taking some sort of laxative at baseline, some of them. Personally, I do not use very aggressive laxatives. I do not like stimulants because of all the cramps that patients have with them. They're already got fluid in their belly, which they're unable to drain. So definitely do not want them to be cramping at that time. I recommend Docusate, which is stool softener, which is pretty mild. If constipation is severe enough for to be causing a catheter problem, I would recommend Miralax.
Okay, what are those? Those are, I guess, brand names. What's the
Oh, sorry about that. Miralax drug name is basically your polyethylene glycol.
Polyethylene glycol, yeah. And the first one was?
The first one was Docusate, and the drug name for Docusate is trying to think of it now. I think just give me a second. It's Docusate sodium. It's basically what's called a stool softener.
Okay.
Mm-hmm.
I don't know if we have that one in Slovenia. I'll check it out. Thank you.
Maybe it's
So,
Dulcolax over there.
oh yes, it is. Oh yeah, thank you. That
Yeah.
was enlightening. Thank you. All right,
Uh-huh.
yeah, that one I do know. Right, thanks. Good. So, how about if there's an inflow and outflow obstruction? Is so usually if it doesn't go out, you've mentioned what's the problem. But if it's difficult to put fluid in, then usually there's something inside the lumen, right? So how do you tackle that?
So for inflow, outflow, both, it could be intraluminal as well as extraluminal. So the
Mm,
within the lumen, mainly your main concern is if there's any fibrin within the lumen.
mm,
Um, Again, the easier way to get rid of the intraluminal either clot or fibrin would be saline irrigation. If that has not worked, intraperitoneal heparin and heparin block of the catheter can often get
mm,
rid of the clot or the fibrin. If that fails, you do need, again, interventional radiology to fluoroscopically inject dye, see what the problem is, and manipulate the catheter. Oftentimes, passing a guide wire can help unobstruct the PD catheter as well.
mm-hmm,
Oftentimes, there can also be, again, catheter entrapment or a kink, um, which you can pick up on plain imaging
mm-hmm.
if non-interventional non-interventional techniques have not resolved the problem. So an extraluminal kink or entrapment, unfortunately, cannot be fixed just by saline irrigation or with intracatheter heparin. You will need some either fluoroscopic manipulation or surgical interventions to help free up the entrapment.
Yeah, that's great, great, great information. Now on to a also common and annoying problem, relatively common, and that's hernias.
Mm-hmm.
Um, how do they always need to be treated surgically, or should we perhaps try the approach as we do with leaks to lower the abdominal pressure? Go to APD, go to supine exchanges. How do you tackle hernias?
That's a great question because the initial response to seeing a hernia is referral to the surgeon. But
Yeah.
yes, preventing a hernia from worsening, oftentimes patients live with hernias forever.
Mm,
There may be contraindications to additional procedures, specifically for patients with cardiac histories, if they're on aspirin and Plavix for anticoagulation and you can't take them off them because of cardiac procedures. So yes, the solution there is to have supine, low volume, automated peritoneal dialysis for those patients. I advise my patients to make sure that their hernia is always soft and reducible. If at any
mhm.
point in time it is not soft and reducible, or they feel it's getting more and more problematic to push it back in easily, I definitely recommend surgical interventions at that time.
Yeah, and it's super important for them to know that if it starts to get painful and doesn't
Mm-hmm.
get better in 30, 60 minutes, that they do visit the emergency because strangulations do happen. Mm,
Yes, and definitely 100% avoidance of constipation for hernias.
again, of course, yeah, very true. These quote unquote simple measures can be even life-saving. Great.
Mm-hmm.
Now another weird presentation, but also annoying for the physician and the patient. Uh, a sudden, let's say, or maybe not so sudden, but just an appearance of a relatively large pleural effusion.
Mm-hmm.
When then you're not sure, is this just because of congestion, cardiac failure, or is there actually a communication between the intra-abdominal space and the pleural space? Uh, so how do you discern between these two? Obviously, there's clinical examination. Do they have edema and so on? But how, if you're not sure whether there's a communication or not, what do you do? How do you check that?
Yeah, that's a great question. Thankfully, an actual hydrothorax related to peritoneal dialysis is relatively uncommon, but it is a very well recognized complication. And oftentimes, with our patients who are undergoing prescription adjustments on and off, you don't know whether it's because they're underdialyzed or it's a sudden complication from peritoneal dialysis. Um, there's historically, it is most common to be on the right side. Left-sided effusions secondary to PD have occurred, but right side is more common. Also, oftentimes, a PD-related hydrothorax presents as a sudden feeling of fullness and perhaps shortness of breath. But the main diagnostic techniques, there's a few that have been demonstrated for peritoneal dialysis patients. The easiest thing to do is, again, CT peritoniography, in which you have iodinated contrast in the peritoneal fluid, and a few hours later, the CT scan can track fluid into the peritoneal space. Another option, which is less commonly used, is peritoneal scintigraphy, which we come across in textbooks. I personally have not used it. Another easy way, which is therapeutic as well as diagnostic, is to do a large volume thoracentesis, which helps relieve the pleural effusion. And also in the thoracentesis, if you have a significantly high glucose concentration, at least 50 to 100 milligrams per deciliter greater than their simultaneous blood glucose, that is indicative that this is not a regular transudative effusion, but is related to peritoneal dialysis.
Sure. And if you do confirm that, then the treatment is also tricky, right? I mean, stopping the dialysis, hoping that it might close, the connection might close by itself. But if that doesn't work, what would you do?
So a few things. Oftentimes, not oftentimes, if there is a definite communication or a diaphragmatic defect that has been identified on the CT scan, I would send them to the thoracic surgeon for a surgical repair. The tricky part is if you don't see anything, then you give them a break from peritoneal dialysis and hope that this communication has healed. If that does not work, then there have been reports of a pleurodesis. However, that is painful. I personally have not had any patients have that. It becomes tricky if you don't find any obvious defect and the leak does not improve with a break from PD.
Yeah, true. Yeah, pleurodesis is quite an aggressive procedure. I didn't know that until I witnessed it. There's a lot of inflammation and
and there's an infection risk also, so you have to be careful.
Yeah, that's definitely. Now, for the last PD question, cuff extrusion. So what is cuff shaving, and does it help in any way?
So cuff extrusion we see fairly commonly with the external cuff of the PD catheter extruding from the exit site and trying to eject itself. Cuff shaving is the process in which the material that is forming the outer cuff is shaved down into just having the plain PD catheter as close as possible. I have had that done for a few patients who have recurrent skin irritation or concerns for exit site irritation and infection because of that cuff, which irritates the exit site and the surrounding skin. So for patients who keep on having recurrent exit site irritation or discomfort because of the cuff, I feel cuff shaving is beneficial. But a lot of patients, once the cuff is extruded, don't have any irritation from it at all. For them, it's more annoying when the cuff is extruding and causing some erythema around the exit site, not really an infection, but that's irritation from the cuff. So it depends on patients to patients. Some patients tolerate an extruded cuff okay. Some patients have skin irritation from it. And the less irritation they have and the less hands go near a delicate exit site, the better. So for them, I would consider an cuff shaving procedure.
That's great. That's great. Thank you. Well, I
Mm-hmm.
mean, this has been very interesting. You've provided some great clinically helpful pointers on how to treat these things. I'm sure that our audience will be very happy about hearing some these things from somebody who's done them a number of times. And now for the last question, we're gonna get a bit more personal. If you're
Sure.
okay with that, it's not going to be terribly personal. It's just we always ask our guests which book, two songs, and luxury item they would take to a desert island, just to get you
Mm-hmm.
know, just to get to know you a little bit.
Mm-hmm. So a book which I read most recently, which I would not mind reading again, is called Lion Women of Tehran. Not political at all. It's all a fiction book. And why I would take that book is there's so many underlying themes that come up in that book about friendship and life and loyalty and moving to different parts of the world, but still having a connection. Like it resonates very deeply with me.
Sounds very interesting. Yeah.
Mm-hmm.
So
And two,
who's the author? It's Lion Women of Tehran. That's the title.
yes, and the author is Marjan Kamali.
Okay, great. Thank you.
Mm-hmm. Two songs. I found it really hard to narrow down to two songs. I would take the Hamilton soundtrack with me because it could go on for hours. And it's so catchy and everybody knows it by heart because it was such a huge sensation. And I would take Paradise by Coldplay again because the first time I heard the song, it was it was famous because it was picturized in the movie The Life of Pi. And it was just such a beautiful visual that I've been hooked onto that song since then.
Yeah, that's a
And
very catchy song. Yeah.
mhm. And luxury item, I would take my Peloton bike so I can exercise while I'm at the desert island.
Smart. Smart. Thank you, Sana. This was wonderful. Thank you very much. Thank you for joining us.
No, thank you for having me.